seminar series webinar. Thank you for taking your time to join us. This training is offered through Research Integrity and Compliance within Compliance Analytics Risk and Ethics, or CARE, at the University of South Florida. CARE supports the university's research community by providing oversight, education, and guidance to help ensure that research across our campuses is conducted responsibly, ethically, and in full compliance with regulatory requirements. We are very pleased to have Dr. Giovanni Finesso with us today as our speaker. Dr. Finesso currently serves as an associate director in the Department of Comparative Medicine at the University of South Florida. He graduated in veterinary medicine from the University of Padova in 2016, where his thesis focused on canine mammary tumors. He later completed a residency in veterinary anatomic pathology at the University of Pennsylvania in July of 2023, where he developed extensive expertise in gross and microscopic pathology with a particular focus on comparative pathology. Following his residency, Giovanni completed a fellowship with the Comparative Medicine Pathology Corps at the University of Pennsylvania, collaborating with both internal investigators and external institutions on research initiatives. Earlier in his career, he also completed a postdoctoral fellowship at the National Institute on Aging, where he studied mononuclear cell leukemia in Fisher 344 rats and its potential implications for epigenetic clock models. Dr. Finesso brings valuable expertise in veterinary anatomic pathology, mouse models of disease, animal handling, surgical procedures, image analysis, and translational research support. His combined experience in pathology and comparative medicine makes him exceptionally well-positioned to guide us through today's session. Today's webinar is designed to provide researchers working with mouse models of disease with practical and conceptual tools to optimize experimental design and planning of pathology endpoints. This session will also highlight useful research resources, key mouse anatomy and histologic landmarks, and the growing role of digital pathology in research. Before we begin, just a quick reminder to remain for the entire session in order to receive credit, and please feel free to place any questions in the chat throughout the presentation. We will collect them and address them following the presentation. With that, it is my pleasure to welcome Dr. Giovanni Finesso, and I will now turn the session over to him.
All right, thank you very much for the introduction. Okay, I think I'm sharing the right screen and not the presenter mode. All right. Good afternoon, everybody. So as the title suggests, today we'll be exploring mouse pathology. We'll go over why it matters, how we can do it correctly, and how it can impact the quality and the interpretability of the research you guys are conducting. To start here, I put just a quick quote from Walt Disney. It was all started by a mouse. And I like it because biomedical research, that couldn't be more true. So that's why it's here. So the aims, the goals of today's lecture are to provide the practical overview of the mouse pathology that you can directly apply to your research and to your projects. I'll briefly introduce some relevant mouse anatomy and physiology, and I'll review best practices for tissue samplings, tissue trimming, to be consistent, have good results. And then cover just fundamental pathological processes, so a broad overview of pathological processes that you could commonly encounter in mouse studies. So this presentation is meant for both investigators that are already working with their mouse models, or also for people actually that are new to in vivo experimentations. Also, I'm going to take this moment to emphasize the fact that my role here is not only as educational, which I'm doing through these presentations, but I'm here also as a pathological resource and service within the comparative medicine department. I can work with you in a consultative capacity. I can add experimental designs, model selection, defining endpoints, and interpreting findings that you might have already collected, as well as I can provide formal pathological assessments of tissues, doing phenotyping studies, and then collect data that is intended for your publications or reports. So my goal is to help ensure that pathological data that is generated from mouse studies are accurate, are standardized, and that the science is solid at the end. I'll repeat this at the end of the presentation, but please feel free to contact me for anything at any stage of your projects. If you want to schedule more focused seminars, we can do that too. Hands-on experience. So please do not hesitate to contact me. Okay, now moving on with laboratory mouse in research. First of all, why is the presentation today focused on mouse pathology? Well, because it's the most commonly used species in biomedical research. At USF, the vast majority of you are using mice for your research, which reflects a global trend. And why we use mice this commonly is because they are easy to breed, they're easy to maintain, they reproduce quickly, and their size makes it cost effective. They also have fairly short lifespans, which makes aging studies not only feasible, but easy to do. Also, they are genetically well characterized with inbreed strains. We have powered genetic engineering tool, which all of these allows us to model human diseases extremely well in mice. Now, with that being said, mice are not tiny humans. There are differences. There are many differences. It is important to know that. Mice and humans diverged evolutionarily about 80 million years ago. And so there are meaningful differences. So to be able to generate meaningful data, to be able to generate translational data, it is essential to understand the mouse on a complete way. So 360 degrees, you know, to know mouse biology, its pathology, and this includes also not only mouse, but specifically the strain of mice that you are using and you want to use for your research. And also it is very important to understand and to really know what it is that you want to assess in your model. So what is your question? What is the thing that you want to understand? And what model are you using to understand that, or which model are you questioning? Choosing the right model, asking the right question is important, and to collect the tissues that is necessary and to generate relevant and meaningful data. And in the end, to have good science. So the first thing that I want to introduce is tissue collection and tissue trimming, because it's one of the first main points where we might see problems and issues, inconsistencies, which translate into difficulty in reproducibility of our results. When you collect tissues from your animals, the first thing you want to do is fix them for the scope of histopathology. The first thing you want to do is fix them. Now I'm going to talk about formalin here specifically, mostly because this is the most widely used fixative for histology. There are other type of fixatives. We don't need to go into the detail now, but this is another thing that, depending on what you want to study and the organ and mechanisms that you want to assess, there might be different fixatives. But talking about formalin, the first really important point is ratio. How much formalin per tissue do you need? And a good rule of thumb is 1 to 10. 1 part tissue for 10 parts formalin. And this is to ensure proper fixation of the piece of tissue that you have and allow adequate surface contact with the fixative. One thing that you absolutely want to do is to avoid overcrowding and overfilling of the container, maintain that 1:10 ratio. The other thing is timing. So you need to allow the tissue to fix for at least 24, I recommend 48 hours, because while I understand that there are worries about overfixing the tissue, especially if there is immunohistochemistry involved, you don't want to lose those markers. 48 hours in formalin is not gonna ruin markers. It allows for complete fixation, because other than overfixing, a very common mistake is underfixing a tissue. And when you underfix a tissue, by the time it ends on the slide and gets stained, it goes through autolysis. It keeps, basically, the process of autolysis keeps going, which means you'll end up with a piece of tissue on a slide that is unreadable or doesn't have diagnostic significance. Once the tissue is fixed and you want to store it, because maybe you are collecting in your collection phase and you want to process it later, most of the tissue that you collect can be then stored after 48 hours in formalin in 70% ethanol. This is true for basically all the tissues of a mouse except the CNS. The central nervous system doesn't store well in 70% ethanol. So I suggest when you do collect CNS, let it fix for 48 hours and then process it. Make it a paraffin blocks, whatever it is that you want to do, but process it right after. Obviously, another main point is going to be the trimming. We'll go over during the presentation. I'll give you a couple of pointers on trimming specific tissues. But again, here I'm going to repeat, if you do need help in collecting and trimming tissues, myself and the comparative medicine staff, we're happy to help you, either train you or do that for you, so that allows for consistencies in your samples, which translates into comparable data and good science. Okay, so here I just put an example of one of the points we just made. One of these samples is properly stored and is properly fixing. The other one isn't. And yes, you guessed it, this one is improperly stored and fixed, while this one on the right is. So here, if you put a whole mouse into a 50 ml conical tube, it's just not gonna fix at all. It doesn't matter how long you leave it there, it's just gonna autolyze. While this is properly collected in its tube with 1:10 ratio. Okay, going into anatomy. Now, before we start talking about all the different systems, anatomy and pathology, we need to have consistencies and we need to speak the same anatomical language. Just a few pointers. In veterinary anatomy, everything that is toward the head, it's called cranial. Everything that is toward the tail is called caudal. Everything that is toward the back is called dorsal. And everything that is toward the belly or is called ventral. Now, this is in comparison to superior, inferior, anterior, and posterior that are more common in human anatomy. There is also proximal and distal, and so everything that is proximal is toward the center of the body, and everything that is distal is toward the, let's say, fingernails, toward the periphery of the body. Okay. So the first system we're going to talk about is the cardiovascular system. Now, the heart in mice, very much like in humans, has 4 chambers. The left and right atria up here in A, left and right ventricle down here. And the layers that compose the heart are very similar to what we see in humans too. The mice also have a pericardium, which is that sac that encloses the heart. And then from the outside in, there is an epicardium, a myocardium, and an endocardium. Now, there are a couple of differences. Obviously, scale is the first one, comparing mice to humans, but also the coronary arteries in mice tend to be embedded within the myocardium, compared to humans. So grossly, it's not necessarily easy to evaluate the coronary arteries in mice. To distinguish left and right, you see how the left is thicker, has a thicker wall compared to the right one. Also, the apex of the heart is composed by the left ventricle, while the right ventricle stops just before. So this gives you a little bit of a hallmark when you want to evaluate the heart. If you find something and you want to give it a geographical location within the organ. Okay, another point that I'll repeat a couple of times throughout the presentation is, depending on, again, the question you want to ask, what do you want to assess, the way that you cut and trim and fix tissue might change. So here we have the example of the heart. The orientation can be either sagittal, you can have a sagittal section like this one, and this is useful to evaluate the four chambers, to evaluate the valves and the leaflets. You can see them here. I go back here to the leaflets of the different valves. While on the other hand, if you want to evaluate the thickness of the walls for a chamber specifically, this cross section would serve you better. So like in this case, when you need to quantify myocardial damage, here there was a ligation that led to an infarct. With this cross section, you can evaluate that lesion better than with a sagittal section. So again, what it is that you want to assess, what is your question, leads to differences in the approach for the tissue. Okay, going through with the vessels. So very much like in humans, mice have arteries and arterioles that have three well-defined layers. We have an intima going from the inside in. We have an intima, a media, and an adventitia. Now, within the intima, this white space is the lumen that contains red blood cells. Just to confirm, we're looking at the vessels, specifically an artery. So understanding also what are the layers within the different kind of vessels might help you avoid over-interpreting or under-interpreting some findings like hypertrophy or inflammation. The other kind of vessels that we have, veins and venules. Now, the differences in the structure, obviously, from the arteries is apparent, but also one interesting point is that in mice, intrapulmonary vessels, veins specifically, like the ones that I'm showing here and here, when they're intrapulmonary veins, they are encompassed, they have a layer of cardiomyocytes. So this pinker layer here in an intrapulmonary vessels of a mouse is not an hypertrophy, is not a lesion. It's a normal finding that is specific to mice, and it's just a layer of cardiomyocytes that the intrapulmonary veins have. So don't read this as a lesion. And here again, we have the lumen, a little bit of red blood cells. Other kind of vessel is the lymphatics. And so lymphatic vessels can be tricky to identify histologically, but a quick and dirty trick, if you want to kind of assess if the vessel that you're looking at is in fact a lymphatic, you can look at the lumen. In this lumen, there are no red blood cells, right? Here we have red blood cells. Here we have red blood cells. In this vessel, we don't. So it plays in favor of the being lymphatics. The wall of the lymphatic vessels are very thin, and so all of these play the role of, okay, I'm looking at the lymphatic vessels here. Recognizing them might be very important in what you are looking at. It might help interpret edema. It might help interpret metastatic spread. We'll see this with tumors. You have metastatic neoplastic cells within one of these vessels. You can lead toward, okay, we have metastasis. So it's useful to know and recognize the kind of vessels you're looking at. Okay, moving with the respiratory system. mice, an important point and distinction with humans is that mice are obligate nose breathers. Why is it important? Because you can have severe clinical presentations that don't necessarily correlate with a severe lesions or a severe pathological finding. So because they are obligated nose breather, even a mild rhinitis, so inflammation of the nose passages, can result in severe consequences and clinical signs. So keep in mind that mice are obligated nose breathers. The overall structure of the lungs is they have one left lung lobe and four right lung lobes. And these could be useful depending on what you're studying. You need to create lesions within the lung lobes. Knowing the anatomy is essential. Another differences with other animals and humans is that mice lack intrapulmonary cartilaginous bronchi. So when you do look at a section of lungs, you can recognize the bronchi for the epithelium. If you don't see the cartilage around them, it's not a lesion, it's not an anomaly, it's a characteristic of the animal you're using. All right, so when collecting and evaluating lungs histologically, there is an important step, which is proper inflation with formalin. So why is this important? Because, as shown here, we have one lung that has been properly inflated with formalin. And again, we can show you how to properly do it if you need it. The other one hasn't. And so what happens if you don't inflate it is that you have a collapse of all your structures. And so especially for minimal, mild lesions that, even though minimal or mild, might be relevant for your project, when the is collapsed, it's difficult or impossible to evaluate. So you lose data by improperly fixing your samples. Okay, gastrointestinal system. Let's start with the dentition. The dentition in mice, as you can see, is highly specialized. They don't have canines and they don't have premolars. Also, they have very specific incisors that grow continuously. Throughout the GI tract breakdown is fairly similar to what we see in humans. There are some key differences, which, for example, include they don't have an appendix. So not a good model for appendicitis in mice. Also, another difference is the stomach. The stomach has a non-glandular or squamous portion and a glandular portion. So if you are looking at a section of a stomach and you see the differences between the two, that is not an area that is with lesions. It might naturally present two different areas within their stomach. Just to keep in mind if you're looking at it. Some, again, pointers when fixing your GI. One good practice is to inject into different portions of the GI with a syringe, some formalin. So basically, you're going to collect all of your intestine, stomach, cecum, and then before you put that in your bucket with the formalin, you probably you can withdraw some formalin with your syringe and just inject it in 3 or 4 different points along the GI. That helps starting the fixation process from the inside out, as well as from the outside in when you then put it in the bucket of formalin. And now this shows a piece of same kind of intestine, so small intestine in both figures. Only one was injected with formalin, the other one wasn't. And what happens is that if you don't inject it, you start having autolysis of the internal structures, starting from the villus tips. Now, there are multiple agents that can affect, can target the villus tips. So if you're working with one of those and you lose the villus tips, needless to say, you cannot assess those, and so you lose data. Okay, again, here, the orientation of your cuts can be influenced by the question that you have, what it is that you want to study. The recurring theme throughout the presentation. So here we have an example of a Swiss roll. Swiss rolls are excellent ways of assessing the entirety of length of, for example, the colon or the small intestine. So if you have lesions that you want to assess throughout the entire length of your piece of intestine, Swiss rolls is the best way to go about it. Cross sections like this one, with a cross section, you can evaluate very well the entirety of the wall. And also it preserves the content of the lumen. So if that is of interest, you do not want to do a Swiss roll, which loses all the content. You want to do a cross section. So yet again, know what it is that you want to assess, what you want to study, and collect accordingly. Okay, salivary glands. So salivary glands are one of those organs that have sexual dimorphisms in mice, which means that males and females have differences in the appearance of their salivary gland. Now, here in these pictures, it shows clearly the submandibular gland, the parotid, and the sublingual. And then here in LN is the lymph node that you find at the end of the chain of salivary glands. Now, the submandibular glands are larger in males compared to females. And not only that, we have differences histologically. Now, what it is that salivary glands, the epithelium contains these very prominent eosinophilic granules that are driven by the presence of testosterone. So when you see these two pictures that I'm showing, they are both coming from healthy, normal, age-matched mice. Only one is male and one is female. And this is one. So males have these very apparent eosinophilic granules. Again, you have multiple mice in your cohort. You're evaluating salivary glands. You see some have these findings, some don't. It's not a lesion. Ones are males, the other ones are females. Kidneys, the urinary system also mirrors fairly consistently the human anatomy. There are some sex and strain specific differences. One of them is the Bowman capsule. So when you think about the anatomy of the kidney, you have the glomerulus that filters, and then the glomerulus is surrounded by the Bowman's capsule, which then collects the urine into the tubules, and then it goes through the process. Now, this Bowman capsule has differences depending on if you're looking at males or females. Specifically, in males, the Bowman capsule is composed of cuboidal, so thicker cells, while in females, it's composed of flatter cells. So here we have an example, and here indicating the Bowman's capsule around the male's kidney, and the Bowman capsule around females' kidneys. You see how flat it is compared to the males. This is not hyperplasia. This is not hypertrophy. Atrophy. So they're both healthy, normal-looking specimens. Just know the differences, or ask us. Endocrine system. I'm going to talk specifically in the endocrine system about the adrenal glands, because it's one of those organs that, again, has some sexual dimorphisms. So the overall structure is similar to what we see in humans. Adrenal glands have a cortex and a medulla, and the cortex is divided into 4 areas in young females, which goes down to 3 in males and older females. So specifically, we have this X zone in the medulla, which is only present in females before their first pregnancy. After the first pregnancy, this X zone atrophies and it goes away. So again, if you're looking at the adrenal glands, this is not a lesion if you're looking at young females. Know what you're looking at, know your scientific questions. All right, hemolymphatic system. With the hemolymphatic systems, even more so, it's really important to know the strains that you're working with. This is because I'm sure you're aware and you might be using both immunocompetent and immunodeficient strains. Immunocompetent strains like the Black 6 and immunodeficient like the NSG or NOG. So there are very wild differences if you compare the hematolymphatic systems of these two strains, starting with lymph nodes. Now, here we have two pictures that are taken at the same magnification, and there is another organ here, this one and this one, used as reference. This is the pancreas in both pictures, and this is the lymph node in an immunodeficient mouse, an NSG, compared to the lymph node of the immunocompetent mouse, the B6. So again, know the characteristics of the strain you're working with. These are very obvious and extreme examples, but just to show the point of know the strains you're working with. Now, this is true for lymph nodes. It is also true for the spleen. So the spleen is composed of a red pulp and a white pulp. You can see how in the immunocompetent strain, the white pulp is nice present throughout, very obvious, while it is not white at all in the immunodeficient NSG strain. Here, just to go over also another characteristic of mice in general, in the spleen, it is quite common to see extramedullary hematopoiesis. Now, this can be one of those confusing findings because extramedullary hematopoiesis in the spleen in mice is common, is normal. However, it can increase in specific pathological situations, in specific physiological states. So this is actually a point where it's nice to know because it raises the importance of having controls to your study subject. So if you have controls, you can say my study cohort has an increased level of extramedullary hematopoiesis compared to the control. So whatever it is happening, it is affecting the hematopoiesis. If you only have the study subjects, you can say that there is extramedullary hematopoiesis, but you cannot tell precisely if it is increased or not based on what you're doing. So here we can highlight the importance of proper controls. And then moving with the thymus, again, just to illustrate yet again the differences in the strain. I didn't even put it here, but I'm sure you can tell which one is the immunodeficient and which one is the immunocompetent. Again, same magnification, just different strains. And that goes with the bone marrow as well. Now, the bone marrow, this is the bone marrow of an immunocompetent, and this is the bone marrow of an immunocompromised or immunodeficient. Quite transparent compared to the immunocompetent because the amount of cell lines is very much reduced. Here, it also raises a good point that if you do want to evaluate the bone marrow, it is very important consistencies in the collection of the bone. So if you do comparisons between the femur and the sternum of the same mouse, you might see slight differences even in the same mouse. So be consistent in the type of the bone that you choose to evaluate, and then in the way, obviously, of collecting and trimming it. But the bone that you choose changes the characteristics of the bone marrow that you look at. And here to just illustrate the histology aspects of an immunocompetent versus an immunodeficient bone marrow. Also, when you do evaluate bone marrow, you always want to correlate those findings, histologic findings that you have from these slides, with the CBC data. Always do CBC data collect CBC data if you do want to evaluate bone marrow. Okay, the skin, glands, and integumentary system. This is another system that has some differences, not only between mouse and humans, but within strains and within even the same mouse, the areas that you want to collect the skin from might have differences. Obviously, strain-wise, there are nude mice and there are non-nude mice. The area of the body where you collect the skin from can vary wildly. And so a couple of examples here, we have the skin from the trunk, so from the back of the mouse, and a little bit higher magnification. It shows all of our beautiful layers. We have the epidermis, a little bit of stratum corneum. We have the dermis with all of the beautiful annexa, and then the subcutis. And so here is a healthy looking normal layers of the skin from the trunk. When we compare this to the skin from the tail, it's wildly different. It's not a lesion, but we can see that the skin, obvious findings immediately, it's thinner, and it has this sort of wavy or undulated appearance, a little bit higher magnification. The epidermis is still there. We have a slightly thicker keratin layer on top. The dermis is much thinner, and the adnexa are much fewer and sparse between. And so again, knowing the characteristics of each area helps not over-interpreting findings. Skins from the ear, it's another quite specific findings here. We have this nice, and just a higher magnification of this area, a nice band of cartilage in the middle, which shows us that we are in fact in the pinna of the ear. And then skin from the muzzle, so the face of the mouse. I put this one here because it has a beautiful structure. That is this one. This is a fimbria or a whisker. And this is basically a highly specialized hair that sits on this sinus, and it gives basically the mouse pressure information, pressure data on the surroundings. And so normal structure, know that this exists if you want to look at skin in the muzzle or the face of the mouse. Mammary glands, another structure that there are some differences with humans, not only in the sheer number of mammary glands, but also in the distribution. So basically, mammary tissues in the mouse goes from the base of the chin all the way down to the inguinal area. So it's very widespread. Other differences that you can see within female mice is that depending on the physiological state, the histological appearance and gross appearance of the mammary gland changes. And as an interesting fact, male rodents do not have nipples. So if you are looking for them in a male mouse, you're not going to find them. And that's normal. And that's the appearance of what you can see. Another structure that I've included here, because it's not present in humans, so it's good to know, not to overinterpret it or misinterpret it, is the zimbal gland. The zimbal gland is this structure that sits right here. It's a specialized sebaceous gland. And it sits at the base of the ear, basically, and it opens actually in the ear canal. So this structure exists. If you see it, it's not weird because it's not in humans. It's normal. They're supposed to have it. Okay, now we can go through some basic pathological processes. And again, I'm going to do a broad overview of the processes without going too much into any details for any of these. But if interested, reach out. We can discuss these in more detail. We'll cover degeneration and necrosis. We'll cover inflammation and neoplasia, cellular proliferation and neoplasia. And these main principles that we'll go over, they apply for all the systems and all of the tissues. Okay, let's start with cell injury and necrosis. Now, cell injury exists in sort of a spectrum. I've included here these two diagrams. This one I find very useful, easy to read for the types of responses that the cells can have to injurious stimulus. Normal cells can either adapt or be injured by the stimulus. And when injured, can either be a reversible injury and going back hopefully to normal or somewhat normal state, or irreversible, which leads to, and we'll see, type of necrosis and apoptosis. This other diagram on the right, I find really useful because it gives you the evolution of the lesions in function of time, which is useful because you can see you apply your stimulus, and the first thing that you see is a decrease in cell function. This is not associated with any visible lesion at any point. And then you start having a biochemical alteration, which you can evaluate, ultrastructural changes, which you can evaluate with electron microscopy, light microscopy changes with histology, and then gross morphologic changes, which you would evaluate during your necropsy. So this is particularly important because it gives you a clear-cut vision of if you are too close from the point of the time of injurious stimulus, you might be catching the lesion here. So you have a lesion, you have clinical signs, but you don't see it histologically, you don't see it grossly because it's too early. Now, we are not talking about weeks, but we are talking about hours or a few days to get to the gross morphological changes. So be mindful at what timing point you are collecting your specimens and what to expect and how to investigate what it is that you want to investigate. All right. Causes of cellular injury vary widely. I have put this one here. We are not going to go through all the pathological ways of causing cellular injury. I've put this one here mostly because there are, as a reminder, that there are normal or physiological processes that ends in cellular injury and cellular death, like cellular turnover, or obviously during embryologic development, cells die left and right because of the development of the fetus. Okay, when we talk specifically about cellular degenerations, we have acute or chronic cellular degeneration. And this slide here is just to highlight the fact that in pathology, terminology counts and is not necessarily always straightforward. We like to play with words. So what happens is acute cellular degeneration, one of the findings we might have is cellular swelling. And here I have two different tissues with basically the same kind of finding, which is acute cellular swelling. Here we can see the liver and these huge hepatocytes, acute cellular swelling. Here we have a piece of skin, and you can see huge cytoplasms clear with the marginalization of the nucleus, again, acute cellular swelling. However, because of the location they take on different, and the state, they take different names. This is called hydropic degeneration. This is called ballooning degeneration. And this is, again, just to highlight the fact that when you read reports from pathologists, you have to be careful on the wording. And so another reason why I'm here for as a good resource, if you need help interpreting already obtain pathology reports, or if you have my pathology reports and you need interpretation of them. When we talk about chronic cellular degeneration and adaptation, I just put this one here to illustrate the differences between cellular adaptation, which we will go over with neoplasia as well, because we have hyperplasia, which is an increase in the number of the cells, hypertrophy, which is an increase in the size of the cells, not in the number, and then metaplasia, which changes the type, and then dysplasia, where basically the cells starts growing in weird ways, and they don't necessarily resemble the original cell line. But we also have cellular degeneration. Now, cellular degeneration can be, for example, atrophy. So we have a decrease in cellular size, and then which reflects in a smaller organ size. But we also have a decrease in function of the organelles within the cells, and then can lead to an accumulation of materials within the cells. And this is a good example of different materials, but that can be very confusing because these two materials are different. This is fat and this is glycogen. Now, there are areas in this slide here that can be confused with this, but there are certain characteristics that distinguish this as fat and this as glycogen. The marginalization of the nucleus by the fat, this web-like appearance of the glycogen. So there are differences which might be subtle but meaningful. And if you're talking about or want to study necrosis and different types of cellular death, you have to keep in mind that they are not necessarily always distinguishable with merely a methicillin and eosin stain. You need immunohistochemistry. And then I've put this one is a great resource if you want to go into deeper mechanisms of regulated cell death. This paper is lengthy, but extremely well done. Talking about necrosis, we have different types. We have, and I've put a couple of examples of the different types of necrosis that we might find. Liquefactive necrosis is characterized by a loss of the cellular margins. So we see here is a liver, this thick band of inflammatory infiltrate, and at the center, a complete loss of cellular architecture. There is no recognizable piece of tissue here that resembles liver. It's all cellular debris and bacteria. This is liquefactive necrosis. Compared to coagulative necrosis, which this is a piece of a heart, and then you have again your thick band of inflammatory infiltrate, but you have in the center still recognizable tissue here. It's all dead cells, but they still have some resemblance of what they were before. And so this is coagulative necrosis. Now, coagulative necrosis is particularly present or characteristic of ischemic injury, while liquefactive necrosis is a characteristic of infectious diseases. Associated with necrosis, we have other findings. Actually, this one is a great example of hemorrhage. All these red blood cells outside of the vessels. This is hemorrhage. And this is a great example of edema. So we have a normal skin here, the dermis, nice and pink. Here it's all expanded by fluid edema. And fibrosis. Fibrosis here is shown with a trichrome stain, normal piece of skin. And then here, all the dermis is expanded by this blue material, which is how trichrome stains fibrosis. Okay, now we can move on with inflammation. Inflammation is a dynamic response of the organisms to infections, for example. And it's a response that involves white blood cells. Specifically, they recruit white blood cells depending on the injury that is caused. And it might result in tissue repair. Now, the type of this slide is a little bit overwhelming, but I put it here just to show that the type of cells that is predominant depends on the type of insult that the organ received. Now, there are also, broadly speaking, the two types of inflammation, acute and chronic. And in each one of these, there is a preferred or predominant type of inflammatory cell. In acute inflammation is neutrophils. In chronic inflammation is lymphocyte and plasma cells. Now, there are tissue and situation-specific exceptions. So how to navigate through those? You ask your neighborhood-friendly pathologist. So I'm here to help you with that, but there are obviously tons of resources to navigate through the exceptions. A couple of examples of different types of inflammation. This is an acute inflammation. We have edema, the normal sample here. And here we have edema, we have some hemorrhage, and a whole lot of neutrophils. This is a classic example of neutrophilic or acute inflammation. This is an eosinophilic inflammation. Now here, the main cell type that we see here is this pinkish raspberry colored cell, which are eosinophils. Granulomatous and pyogranulomatous inflammation, another kind characterized by actually a combination of neutrophils and particular type of macrophages, epithelioid macrophages specifically. So depending on the type of cell, we have different type of inflammatory response, which leads us to different types of insult. Okay, lastly, we have cell proliferation and neoplasia. So the neoplasia arises from a dysregulated proliferation. Again, very broadly and very generally. There are some pre-neoplastic changes that we might see. In this case, we have illustrating the diagram, hypertrophy, hyperplasia, metaplasia, and dysplasia, which we talked about earlier, which can result in neoplastic or neoplasia, neoplastic change. Now, this diagram here, I particularly like because we talked about the inflammation. It gives you a very easy breakdown of the three main types of neoplastic, the three types of cells that become neoplastic. We have epithelial, mesenchymal, or round cells. These are the three cell types. And so when epithelial cells become neoplastic, we have adenomas or carcinomas. When mesenchymal cells become neoplastic, we have either a benign or a malignant form too here, and sarcomas are the malignant form of mesenchymal cells, tumors. And then we have the round cells. Now, benign and malignant form of the round cells here, we have basically the white blood cells tumors or red blood cells tumors. Well, no, red blood cells are mesenchymal. So the white blood cells tumors are part of the round cell tumors. So here is a progression of what we've seen in the diagram before: normal skin, some pre-neoplastic changes, and end up in the neoplastic lesion, which is in this case a squamous cell carcinoma, just to show a histologic equivalent of the diagram we showed before. Okay, to distinguish benign versus malignant neoplasias, there are different characteristics, different things that we can account for. We don't need to go through, I mean, you can read the table, but the bottom line is, as we all know, benign are slower growing, they don't invade, they don't metastasize, while malignant ones tend to be different from the tissue of origin. They metastasize, they invade locally, and they have high mitotic count. Talking about metastasis, here we go through, there are different ways that the tumor can metastasize. It can go through lymphatic vessels, it can go through blood vessels, it can metastasize via what is called seeding or a transcelomic metastasis, or via venereal spread. Now, the way that the tumor chooses to metastasize is not fixed. So there are, as you can see here, I put that lymphatic vessels are common for carcinomas, so malignant epithelial cells. This is true most of the time. It's not fixed in stone. It's not written in stone. So majority of the time, malignant epithelial tumors, so carcinomas, metastasize via the lymphatic vessels, while malignant tumors of the mesenchymal cell line metastasize through blood vessels, so hematogenous line. So a squamous cell carcinoma might be seen in a lymphatic vessel, while a sarcoma is seen in the blood vessels, as a general rule. This seeding or transcelomic is what would happen as is the risk of removing a tumor and with an open abdominal cavity, because if the tumor touches other surfaces, it's called seeding, and this creates what is called carcinomatosis. And then there is the venereal spread. A couple of pictures here. We have the lymph node. You see here the neoplastic cells invading what tries to be the normal and functional lymph node, but it is being invaded. And so how can you tell if a neoplasia is malignant before it metastasizes? Because once it metastasizes, we are sure it's malignant. But how can you tell before? Well, through histopathology. And so there are certain characteristics that we can look at, borders, the growth rate, and the level of anaplasia that can lead us to one towards the other. So I have here a couple of slides to go through, a couple of pictures. This is a benign tumor, and you can tell that because it's nicely encapsulated and bordered, and it doesn't branches out. However, you can see it is pushing the tissue surrounding the tumor a little bit. So it has this sort of mass effect, pushing the neighboring tissue away, but it's not invading it. Differently, a malignant tumor is not pushing anything, but it is branching and invading the surrounding tissue. So this is pointing us toward the malignant tumor. The other point is the mitotic figures. So obviously, mitotic count is one of the main things for a lot of tumors to know and to count above a certain threshold, above a certain number of mitosis. That is indication of malignancy. So the more active it is, the more likely it is to be malignant. And then when we said the level of anaplasia, which means how much does the neoplastic cells resemble the original cell it's coming from. Benign tumors have very low to no anaplasia. This is an example of a leiomyoma, which is a tumor of the soft muscle, the smooth muscle, and it's very benign. And the neoplastic cells that are these very much resemble normal smooth muscle. Contrary, a severe anaplasia is indication of malignancy. So these cells do not resemble any other sort of cells. They are all over the place in terms of sizes, in terms of shapes. This is high level of anaplasia, an indicator of malignancy. And lastly, I'll go very quickly over digital pathology. In one sentence, digital pathology allows us to do basically everything we are doing with the normal light microscope, but to add that quantitative data, and obviously allows us to work remotely. So these are light microscope tools, and this is what digital pathology uses. We have the scanners, but on top of that, we have different softwares. Now, these are here only for examples. I have been using QPath lately. I have had experience with Aperio as well. But basically, it's just to illustrate again the point that with digital pathology, on top of the evaluation of the slide, we can actually take measurements and allows us to work from different points. So if you have a slide that is scanned, I can look at from my office, and we can exchange and do consults via Teams, via any sorts of ways. So it makes it easier to work in collaborative settings and to have quantitative data, which is not nothing. Now, the digital pathology is relevant in teaching, as we said, in research, as we just said, and also in diagnostic. So it is taking more and more space. Okay, now to summarize, take-home message, I think I've talked enough. The pathology service within the comparative medicine department is here to support you on different parts of your project. It doesn't matter where you are in your project, we can probably support you if you want. We can support you in the planning of your experiment. We can support you in the execution of your experiments, collecting tissue, doing the trimming, and we can support you in the reporting of pathological findings for your publications, for your reports. So yet again, please do not hesitate to contact me for any of your needs throughout your experiment, before, during, after, for consultations, for actual services. if you want different sessions like seminars, I'm happy to provide those too. Or if you need hands-on teachings or experiences, me or comparative medicine department, we are happy to provide that. My email, my room, so you can find me. And these are references and acknowledgements for this presentation. And thank you very much for your attention.
Thank you, Dr. Finesso. Are there any questions at this time? Do we have any questions in Q&A? Here we go.
And if you ever have a question afterwards, you have my email.
Yeah, at this time, we don't have anything posted in the Q&A section, and I didn't see any in chat.
Perfect.
So, yeah, well, if no one has anything, then I guess that's all. Thank you very much, Dr. Finesso. Thanks again for this wonderful presentation.
Thank you. Thank you. Have a good one, everyone.